this is Stevie Myers with Maryville University, and I'm performing my head-to-toe assessment for Advanced Health Assessment. This is my patient Brett, and he has volunteered to be with us today. Prior to the exam, Brett was instructed to empty his bladder to get into some comfortable clothes, or he could have chosen a gown. We got his vital signs along with his height and weight, and he also did the Snellen and Rosenbaum vision screenings. I'm just going to start, whenever I first see a patient, I always assess their mobility, their mood and manner, and make sure that their dress is appropriate. Once we have them in a gown or in comfortable clothes, then I would just start with inspection. And first I'll just inspect the skin, and we'll start with really the face. I would make sure there were no lashes or rashes. Everything is symmetric. His facial features are symmetric. There's no visual trauma, lesions, nodules, protrusions, anything abnormal. After inspection, I would just feel his scalp and make sure that it moves freely. Kind of feel his hairline and assess the hairline to make sure that the hair is evenly distributed. And just kind of compare his facial features here. And go ahead and open your mouth, assessing the TMJ here, and close. And was there any pain there? No. So we'll assess the TMJ, no crepitus or pain there. And then we're going to go ahead and start with the eyes. I'll just palpate along the brow, make sure there's no nodules, lesions. The brow extends to the outer canthus of the eye. We are just assessing the eyes in general. The eyelashes extend outward. There's no exudate. The lacrimal apparatus appears normal. There's no tenderness or redness. I'm going to look here just at his conjunctiva, and they are pink. There's no foreign bodies. There's no exudate. They're not red, pale, or yellow. I'm comparing here his pupils, and they are the same size. And then I'm going to test his light reflex. We're going to first do the direct. I'm just going to have you just stare right there at the camera. The direct and the consensual light reflex, and we'll do both sides, the direct on the right and the consensual looking at the opposite eye. And so his light reflexes are there. Let's do accommodation. Go ahead and stare out to the wall, and then now look at my pen light. Yes. So his pupils are equal, round, reactive to light, and show accommodation. So that will take care of the eyes. We've already done the Rosenbaum and the Snellen vision screen. So now we're going to move on to the nose. And I would just make sure that the nose looks symmetric, the septum doesn't look deviated. I would look in to see the turbinates are not red, it's your nose, red or swollen. There's no nasal polyps, no pain or tenderness here.
No. And
then I'll check the patency of the nostrils. I'll include this nostril, breathe in. Were you able to breathe fine? Mm-hmm. And the other side? Yes. So everything is fine there. I'm going to go ahead and palpate the frontal sinus here. And are you feeling any tenderness?
No, not.
No. So no tenderness on his sinuses. Then we will inspect the ears. I'm making sure that the top of the pinna is above or equal to the inner canthus imaginary line here. Palpating the auricle, there's no nodules or lesions. Everything looks fine. We'll check both sides. And then we will take a look side. Tympanic membrane looks good. What? Looks good. And then we're going to do some. We're going to go ahead and move on to the mouth. I'll do the fields of gaze with the cranial nerves. Okay. So gloves, but the mouth looks good. The lips are smooth and pink and moist. You want to make sure that the tongue is pink and moist. You're going to inspect the teeth and make sure there are no missing teeth or cavities. You're going to look at the dorsal side of the tongue. Go ahead and raise your tongue. Where you would be checking for oral cancers and both lateral aspects of the tongue as well. Back to the posterior pharynx, the uvula rises midline, soft and hard palate look appropriate, and everything looks good in the mouth. Okay, and I'm going to go ahead and palpate lymph nodes now. So we will start with your submental. You can just relax your head. Submental, submandibular, tonsillar, preauricular, postauricular, occipital, superficial cervical, deep cervical, posterior cervical, supraclavicular, and if you'll raise your arms. And we will also palpate axillary nodes. Okay. Now, I feel like we've gotten everything. This was the maxillary sinus. I don't think I ever said frontal and maxillary sinus. Then I'm going to make sure, checking for the neck, that he has good passive range of motion. Just move your head all the way to the right, and then all the way to the left, and up and down. And his passive range of motion is good. And now we're going to move on to the neck. And I'm going to just inspect first, of course, for rashes, lesions, nodules, any goiter that I could see. And then I will palpate here and just make sure the trachea rests midline. And then I will also palpate the thyroid gland to see if it is enlarged or any goiters. So it just right there. I'm also making sure that his neck is midline with his body. Then I'm going to auscultate for bruits over the carotid artery as well as over the thyroid gland. And that sounds very good. Okay, next I'm going to move on to just the upper extremities. And I'm just going to inspect first for any rashes or lesions or abnormalities. I would palpate with the back of my hand to see the temperature is warm, skin is moist, the turgor is good. I would check the capillary refill to make sure that it refills quickly. Everything looks good there. I think we'll do the cranial nerves. I'll be checking first for pulses, brachial, and radial. And you compare these bilaterally to make sure the rhythm and rate is normal. I think I'll move on to cranial nerves. For cranial nerves, we will start with cranial nerve 1. Cranial nerve 1 is olfactory, and I'll have the patient close his eyes. I would give him a familiar smell and ask him to tell me what he smells.
Vanilla.
That's cranial nerve 1. Cranial nerve 2 is the optic nerve. For the optic nerve, we would do the Rosenbaum and Snellen screenings, which we did prior to exam. Cranial nerves 3, 4, and 6 we would assess together, and these are with some vision testing. So we'll do first the cover-uncover test. I'm going to have you cover your right eye, and I'm assessing this pupil. And uncover, look straight ahead, continue to look straight ahead, and then cover your other eye. And now I'm going to do cranial nerves 9 and 10, the hypoglossal and vagus cranial nerves. I will assess him saying, ah, and the uvula rises midline. Go ahead and open it again. And I'm inspecting this hard and soft palate. And I would also give him something familiar to taste. I would have him close his eyes maybe, but the taste reflex is part of those cranial nerves. We're not going to do that today. Okay, and that takes me to cranial nerve 11, which is the spinal accessory cranial nerve. And I would have my patient shrug his shoulders against my resistance. Shrug. No, shrug. Shrug my shoulders, okay. And then turn your head this way, opposite my, okay. And then this way as well. Okay, and that's the spinal accessory test. And then cranial nerve 12, which is the hypoglossal. And the hypoglossal, I would just have him stick out his tongue, and I would make sure that it is midline and isn't deviating to either side. Okay, so that concludes the head and neck and face and arms. We're going to go ahead and move on to the anterior chest. And first I would just inspect and make sure that I can't see any thrills or heaves or lifts. There's no rashes, everything looks normal here. I would palpate over the precordium and just feel for normal rate and rhythm. Making sure there's no heaves or lifts. I would listen for heart sounds with the diaphragm. And we will do the aortic area, which is the second intercostal space, right sternal border. Pulmonic area, second intercostal space, left sternal border. Erb's point, third intercostal space, left sternal border. Tricuspid. Tricuspid is the left sternal border, fourth intercostal space. And the mitral area is left sternal border, mid-clavicular line. Then I'm going to have my patient lie down. And I'm doing more inspection here of the abdomen as well to see if it's concave, convex. I'm going to, let's do lungs. I will listen for breath sounds. And I compare breath sounds bilaterally. And I'm just looking for no adventitious breath sounds. I would have the patient take deep breaths in and out. And I would listen to breath sounds both anteriorly and laterally here. Take a deep breath. And after I listen to breath sounds, I would do percussion. Any dullness would tell me that he was having maybe a pneumothorax or a pneumonia or something. So I heard no adventitious breath sounds, and there's resonance over his lung fields. I will do tactile fremitus as well, where I'm having the patient say 99.
99, 99, 99, 99,
Both anterior and
99,
laterally.
99.
That all sounds really good. And Okay, and now after Tital Frementis, I will, I'm gonna move on to the abdomen and we'll do this anterior part of his chest and then we'll move on to the posterior part next. So for the abdomen, again, I look to make sure if it's concave or convex, and after inspection, I will auscultate. And I'm gonna listen to bowel sounds in all 4 quadrants. And you can listen for up to 2 minutes if you don't hear any bowel sounds, but you're making sure that they're not hyperactive or hypoactive. And after I listen in all 4 quadrants, I'm also going to, with the bell of my stethoscope, listen over the aorta for grooves and for the renal arteries. And iliac, and femoral. I'll also palpate over the carotid artery to make sure the rate and rhythm is normal and there's no heaves or lifts. And after this, I will do percussion. And it should be tympanic over gas-filled areas and dull over organs. And then I'm going to palpate with soft palpation. There shouldn't be any tenderness. I shouldn't feel any masses. This light or soft palpation is preceded by the deep palpation. And then I would also test the abdominal muscles, and the umbilicus will deviate towards the side that I kind of tickle. Then I'm going to percuss for the liver. And I would mark where I first heard it change from tympany to dullness, and then I would percuss up. And I would mark that as well, and in the midclavicular line, the liver span should be about 3 to 5 centimeters. I'm also going to try to palpate for the liver. And you can take a deep breath. And it should maybe roll under your fingers, but I don't even feel it, so it's not enlarged. And then I will do the same for the spleen. Take a deep breath. I'm unable to feel the spleen, which is good. And I will percuss over here just to rule out an enlarged spleen. Okay, I'm going to have you go ahead and sit up and face this way. Actually, can you spin all the way, your legs all the way around? All the way around. I'm going to do your back. Now, for the back, I'm going to inspect first for rashes or any deformities. It should be symmetric here. I'm also just looking at his respiration rate. Everything looks good here. I'll listen to breath sounds. And I already listened to the lateral aspect, so I won't need to redo that. So that's good. We'll do some percussion here. Good. And we will also do the thoracic expansion, I just want you to take a deep breath for me. And the thumbs should move symmetrically out as the thorax expands. And we're also going to do a diaphragmatic excursion. I'm going to have you take a deep breath and then exhale all the way out. And I would mark where the percussion sound changes. I'd mark here, and then I'm going to have you take a deep breath and hold it. And then I will mark where the changes again, and I should have about a 3 to 5 centimeter space on the diaphragmatic exertion. Okay, so that looks good. I'm going to have you go ahead and turn back around. You got your heart, your lungs, your abdomen. On the lower extremities, I would touch here too. Make sure everything is warm and dry. I would check his feet and make sure that they're warm. The capillary refill here is important. We're going to check pulses. We would do popliteal pulses. And we would do posterior tibial. Let me do this at the same time. And we would do dorsalis pedis pulses. And we would compare bilaterally, making sure they're present, 2 plus, and equal rate and rhythm. So that looks good. I'm going to have you stand up for me for a second. Oops. And turn around. We're going to assess now for the CVA tenderness. And I would just put my hand over one side or the other and do some percussion. And if the patient had pain, then that would be CVA tenderness. Okay, go ahead and have a seat. We're going to do some reflexes now. I'm just going to have you rest your arm. Just look away so you can't tell. And we elicit the reflex on both sides. Very good. And the knee reflex. Very good. And the Achilles reflex as well. Good. Good. That is good. And now we're going to do upper and lower extremity strength. So I'm just going to have you hold your arms out like this, and don't let me pull away. Good, and don't let me push away. Good, and then put your arms out to the side. Don't let me push them down. Good, don't let me pull them up. Good. For the lower extremities, I would have the patient pull against me. Good, good, and then I'm going to try to push up. Good, good. We would probably do your feet too. Just push up against me, and hold your fingers out like this, and don't let me push them together. Okay. Okay. I think that concludes our head to toe assessment. Thank you.